It is my privilege to introduce my buddy, Dr. Steve Woolf, member of the Institute of Medicine, Director Emeritus of the Center on Society and Health at Virginia Commonwealth University. He is the Professor of Family Medicine and Population Health. He holds the C. Kenneth and Diane Wright Distinguished Chair in Population Health and Health Equity. And for years, decades, he has worked to address issues related to health equity through outreach to policymakers. Here he's testifying before Congress and the public, consulting, media outreach, speaking engagements. Steve, thanks for being here with us today, and I'll turn it over to you.
So we're going to talk about social determinants of health and the role of race and racism. And hopefully I'll do a good enough description of what I'm trying to show in the slides that it won't be too much of a problem that you can't see it. So the next slide, if this is working, should be showing you a graph of midlife mortality for Americans ages 25 to 64. This is going back from 1999 to 2017. So let me move on now. So this slide is showing the same data, the US population 25 to 64, but it's broken down by race. So I know it's hard for you to see probably, but this line at the very top is the mortality rate for non-Hispanic Blacks. And so what you can see right away here is that although midlife mortality has actually been increasing in the white population, that's this white, this blue line here, as it comes to mind, is translating this into something meaningful in terms of its impact on our health. And many years ago, I became involved with studies that tried to quantify this. For example, this was a paper that was published in 2005. The lead author was David Satcher, the former CDC director, and basically showed that about 80,000 Americans were losing their lives each year because of this disparity in mortality rates between African Americans and whites. Later on, we published a study in the American Journal of Public Health, this is in 2004, where we actually estimated that over the course of a decade, more than 880,000 Americans died who would not have died if the Black population had the mortality rate of whites. So I want to take a few minutes to just sort of talk about what are the factors that are responsible for big health disparities like these. Well, they really come down to what we would call the social determinants of health. So in this diagram here, you see health in the middle of this diagram. And these circles around it, which are probably completely illegible to you right now, are factors like education, income, housing, transportation, jobs. Healthcare is on here. It happens to be over here at about 8 o'clock. But healthcare only accounts for about 10 to 20% of health outcomes. So it's important, obviously, but it's not telling the whole story. Much of what shapes the health of Americans and what drives health disparities are differences in access to the social determinants of health that in our country are very much organized by race and ethnicity. So I don't know if you can read this, but over here on the left, I have race and ethnicity because in our country, race and ethnicity determine access to these social determinants of health. So access to education, access to affordable housing, access to transportation, access to good jobs that pay livable wages are all patterned around race and ethnicity. And it's that primarily that drives much of the racial and ethnic disparities that exist. Maybe during the discussion group, we can talk about the other piece that's not explained by this, which has to do with the direct biologic effects of discrimination on the body and on our genes that also contribute to those disparities. And over here on the right, I just showed public policy because really all these circles on this chart are shaped by public policy. And later on, I'm going to be talking about that in terms of both federal and state and local policy. So when we think about life expectancy, it's important to think about geographic scale. For example, this is a map of Chicago. And although you probably can't make it out, what's shown here are little census tracts within Chicago. And the darker shading that you can see here represents the much lower life expectancy that exists in the south side of Chicago. We've made similar maps like this that are meant more for public facing purposes like news media. This happens to be a life expectancy map for Richmond. And what you can see here, actually you probably cannot see, is a 20-year gap in life expectancy between the census tracts where Gilpin is located, the public housing development, and just a short distance away in Westover Hills, a life expectancy that's 20 years longer, a difference of 83 versus 63. A few years ago, Richmond Magazine took this data and presented this graphic, which you probably can't see either, but it's basically showing how these life expectancy numbers in Richmond correspond to the life expectancy in other countries. And so, for example, Gilpin Court's life expectancy falls somewhere between the life expectancy of Afghanistan and Ethiopia. And this is giving you a sense of perspective about the kind of health conditions that many Americans face depending on what neighborhood they're in. You can take neighboring census tracts that have these stark differences in life expectancy and ask the obvious question, what's going on here? For example, right now I'm showing you a map of 2 census tracts in Montgomery County, Maryland, on either side of Interstate 270. On one side of the interstate, if you exit to the right, life expectancy is 77 years. On the other side of the interstate, if you exit to the left, life expectancy is 83 years. So just taking that example, two census tracts that are really right across the highway from each other, yet have a 6-year difference in life expectancy. And then look at the census data on those 2 census tracts. Again, you may not be able to read the numbers in this table, so you'll have to take my word for it. But what this table is showing you is that if you compare the living conditions in those 2 census tracts in terms of high school education, English proficiency, health insurance coverage, housing costs, et cetera, poverty rates, there are stark differences between these 2 locations. So you have 2 places that have very different conditions affecting health. And in the next slide, I'm showing you the racial and ethnic composition of those 2 very different census tracts. And the bottom line here, which is not going to come as any news to this audience, is that the population that has the much better living conditions is disproportionately white, whereas the population with the more adverse living conditions are disproportionately people of color and foreign-born immigrants. So how did this all come to be? And the first thing to talk about is that race is not a biologic factor. Race is a social construct. It's something that our society has created as a basis for patterning access to opportunities. And so I'm going to take a little bit of time to talk about racism as a determinant of health, as opposed to race as a determinant of health. So when we talk about racism, a common term that's used is systemic racism, the notion that racism is baked into our society. That includes structural and institutional racism, which refers to features of the structures in our society, school systems, law enforcement, courts, healthcare, that have built into the way they operate conditions that are disproportionately harming people of color. Interpersonal racism refers to the kind that we would see if people are overtly threatening each other or becoming violent, and even microaggressions fall into this category. Intrapersonal racism reflects the extent to which people internalize this discriminatory view. And this has been documented, for example, among African Americans who grow up exposed to these kinds of attitudes, who begin to internalize those sense of lack of self-confidence and self-efficacy because of discrimination. It's also important, as the right-hand side of the slide shows, to think about past and present. So I'm going to talk a little bit about history because there's a long history of racism in our country, but we also have to think about modern perpetuation. This is alive and well in the United States. So many of these old black and white photographs that I'm going to show you really are still describing conditions that we face now today. Because I'm talking to a clinical audience, I want to clarify that healthcare is also a potential home for systemic racism. By definition, systemic means it's baked in throughout all aspects of our society. and healthcare, and frankly, medical research is no exception. So in the case of healthcare, when we talk about this, we're talking about structures that block access to care, such as lack of health insurance coverage or resources for co-payments, lack of access to providers and healthcare facilities in communities of color. Once you get into the clinical setting, implicit bias in how clinical decision-making is done, and then, of course, barriers to disease management and follow-up that people of color might systemically face. So there's a long history of this, as I said, and here come the black and white photographs. There's a quote from Martin Luther King that I like, where he says, "We are not makers of history, we are made by history." My only quibble with this is that he was a maker of history, obviously, but his point was that you have to go back to this backstory to understand how we got to where we are today. So, our minds immediately go back to the sort of Jim Crow notions of how people such as the gentleman at this lunch counter were traumatized by people who were engaging in overt and terrorizing racist behavior. But it's really important to dial back in time. So, for example, here in Virginia, it's noteworthy that in 1902, the state rewrote its constitution for the express purpose of blocking the access of Black people to vote. Shown in the center of this slide, which I'm sure you cannot read, is a quote from Virginia Senator Carter Glass, a guy who later went on to become a member of the cabinet and ended up on the cover of Time magazine. But he overtly said when this Constitution was rewritten that discrimination, why, that is exactly what we proposed. That is exactly what this convention was elected for, to discriminate to the very extremity of permissible action. And on it goes. So it was an overt and explicit effort to block, in that case, access to the polls, which of course we're still dealing with today. But you really have to, especially in Virginia, dial the story all the way back to the beginning to really understand the origins of what we call now white privilege, but also the history of this systemic exclusion of people of color to access to opportunity. It obviously includes enslavement, which began in the 1600s, but also has much to do with the access to wealth and power that came to the British landed gentry who originally took the land that we now know as Virginia. This particular slide is showing an old map from the 1640s of what was then called the Northern Neck Proprietary, which is today's Northern Virginia. That entire gigantic tract of land was given as a gift by King Charles to several of his political supporters, and then they started splitting up the land among themselves, which ultimately turned into tobacco plantations, and they got their wealth from an enslaved economy. But that's how far back you have to go to really understand the origins of some of these census tracts. In a bit of self-promotion here, I'm going to put in a plug for a project we recently completed that goes into the history in extensive detail. What's shown here is the homepage of a website you can go to for this project, which is called Deeply Rooted, and talks about how the history of African Americans in Northern Virginia helps explain the kinds of disparities we see nowadays. And if you just want to quickly know the URL for it, it's called historyfortomorrow.org. That's all one word, History for Tomorrow. Okay, so let's move on. Redlining. This is an example that sort of a go-to example that many people think of in terms of thinking about how past policies shaped current conditions. Redlining, of course, refers to the practice that began in the 1930s in which home loans, the eligibility of potential homeowners for getting home loans was differentiated based on where they lived. And maps were created, and the red colors of the map were signals to banks and other lending agencies that they should basically not issue home loans to folks from that part of town. And this is an example of a policy that basically systematically excluded Black and other disenfranchised populations from access to home ownership, and with that discriminated against their access to wealth accumulation, whereas the white folks who were more readily getting loans were able to buy their homes, build their equity, and pass that on to their children. This occurred throughout the United States. It occurred in Richmond. Shown here is a historic marker that you can go visit in Jackson Ward, showing what was once a vital and vibrant neighborhood of Richmond in the 1800s, called Jackson Ward. Some people called it the Harlem of the South. Shown in this photograph are historic buildings like the Eggleston Hotel and the Hippodrome Theater, where Duke Ellington and Ella Fitzgerald and many other Black entertainers performed. The picture shows a long line of customers waiting to get into the theater. But then along came the 1950s and the desire to build the interstate highway system. And in a practice that actually took place in most cities across the United States, the planners who were deciding where to route the interstate ran it right through the Black neighborhood. So the Interstate 95 actually bisected Jackson Ward. And, shown here in this photograph, you can't make it out perhaps, but it looks a little bit like Ukraine does right now. Demolished buildings that look like they've been hit by a bombing raid, but this is actually from the Turnpike Association leveling homes in Richmond to open the access to I-95. A church that was the center of social activity in Richmond, the Sixth Mount Zion Baptist Church, was slated for demolition as well. The interstate was supposed to go right through this building, and only through a real activism by the Black community were they able to persuade the builders to route the highway just behind the back wall of this church. So this is a picture taken at the time that the interstate was constructed, but any of you who drive down I-95 can just look up from your car as you pass this to see how close the interstate comes to that church. And the result of these kinds of physical and social barriers that were created by interstate highways and other kinds of infrastructure that was built into urban design create the kinds of disparities we live with today. So in this example, on the left-hand side of the slide, we're showing the redlining map for Richmond from 1937. On the right-hand side, modern data on life expectancy. This kind of mirroring of life expectancy plays out with other factors like poverty and so forth. And it's true in virtually every city that I've visited. This happens to be Syracuse, New York. The 15th Ward was the equivalent of the area of Richmond that we were just talking about. This is the construction of Interstate 81 through Syracuse, right through the Black neighborhood again, bisecting their ward where the very socially vibrant Black community was located. And as I said, those redlining maps match up very closely with where we see persistent poverty in modern day, where we see people struggling with limited social services, inadequate educational attainment, homelessness, crime, other factors that are all historic legacies of these past policies. Another example of those policies is restrictive covenants. These were policies that were instituted beginning in the 1920s, really, in many communities, that basically wrote into the deeds and the policies for homeowners that they could not sell their homes to what they called non-Caucasian home purchasers. This is an example from the Indian Spring Club restrictive covenant. This was a neighborhood in Silver Spring, Maryland, in which you can see the plot for the neighborhood, and in it was this language that you can't read on the slide, but basically bars sales to non-Caucasians. If you zoom forward to modern day and look at the makeup of the census tract where that restrictive covenant applied, you see this white population sitting right in the middle of surrounding tracts that are largely communities of color. So that, if you, in a way, segregation of white people is really a legacy of that restrictive covenant. Here again, I don't expect you to make it out, but on the left-hand side is showing you restrictive covenants in Silver Spring, Maryland. On the right-hand side, the Healthy Places Index that our center at VCU has calculated which looks at the conditions for health in neighborhoods. And again, you see this alignment. The places that had restrictive covenants decades ago are today the same places that struggle in terms of their health. I'm going to wrap up soon, but I want to talk a little bit about states, because we've been focusing a lot at a very granular level about census tracts and local neighborhoods, which is very vitally important. But as this map shows, our health also varies at the state level. And this shows a rather characteristic pattern where you see adverse health conditions in the Deep South, many health conditions, diabetes, stroke, etc. If you look at them on maps like this, you typically see the same kind of pattern. But if you look more carefully at the data, you find something rather interesting. So New York right now has the third highest life expectancy in the United States. But if you go back in time, and that's what this slide is showing you, it's comparing you life expectancy between New York and Oklahoma. If you go back to 1990, which wasn't that long ago, at least for someone my age, in 1990, New York's life expectancy was actually lower than Oklahoma's. And then something interesting happened in the 1990s. The curve started, they started parting company from each other. If you can make it out, the flat line to the right is basically showing Oklahoma's life expectancy pretty much stagnant, while New York's life expectancy climbed dramatically to its current position where it is now third highest. That's a pattern that we've seen in our data looking at multiple states. In the 1990s, health outcomes began to diverge more dramatically between the states. And if you either lived through this as I did or have studied the history of what happened then, you may remember that during the Reagan administration in the 1980s, began a policy of devolution, of trying to shift power and resources from the federal government to the states. That was part of an effort to downsize the size of the federal government and give power back to the states. And with that came block grants and other authorities that increasingly were transferred to the state level. And states made different choices about what to do with those resources. So some states, as it relates to health, made choices around policies like Medicaid and also earned income tax credits, minimum wages, investments in education, and so forth, that sent their health trajectory in one direction, whereas other states had different priorities, and the health of their population paid the consequences, in my view. So we're talking about racism and racial and ethnic disparities. It's important to recognize that those disparities also differ by states. This is a slide from a project called the HOPE Initiative, which you're welcome to look up after the presentation. It's hopeinitiative.org. This was a project that we were involved with at VCU, but it was funded by the Robert Wood Johnson Foundation. And what it documents is the level of racial and ethnic disparities in different states. Again, I don't expect you to be able to see this slide, but what it's contrasting is Alabama, Mississippi, North Carolina, and Virginia. And it's showing you the degree of disparity in a particular health measure, which is self-rated health, based on racial and ethnic group. And the point of the slide is the disparities look very different. In the case of Mississippi, there's very little disparity. Most of the racial and ethnic groups are clustered together, whereas in a state like North Carolina, the dispersion is much broader. There's a much wider racial and ethnic disparity in that state. And the point of this is simply to say that the policies that are responsible for health disparities also operate at a different state level. This slide, which you can probably make out, is showing 6 maps of the US. Each of those maps represents a different racial and ethnic group. So what it's showing is that even within a racial ethnic group, we see stark variations in health outcomes by states. So for example, in this map here, which is the Hispanic population, you can see that Texas, for example, has particularly poor self-rated health than other parts of the country. But the map looks different based on the racial and ethnic group. So why is this? Well, it has some degree to do with differences in demographic and economic circumstances between these different states, but it also has a lot to do with policy. So for example, in this slide here, this is a study that looked at the relationship between the earned income tax credit and birth weight. There's been a body of research showing that the two are related, and this is an example of those kinds of studies. Again, I don't expect you to see it, but the important takeaway from this graph is that states that had higher EITC policies, higher earned income tax credits, experienced much higher birth weights than those that had more restrictive policies. We've seen many examples over the years of where policy decisions at the state level mattered. And for some years, I've been giving talks on this for quite a while. My go-to example was the Flint, Michigan water crisis. That's an example where state government got involved with overriding the authorities of local government, a procedure called preemption, which by law allows a governor to override a mayor or a county government, and in ways that both affect public health but can affect other factors as well. And that was partly responsible for the Flint, Michigan water crisis. And I used to give talks on this and people's eyes would glaze over, but then came along a very vivid example of the influence of states on health outcomes, and that was COVID-19. Here came along a circumstance, it was almost like this eerie natural experiment, where public health policies that would help prevent transmission of this virus and later on help enable access to a highly effective vaccine were approached very differently at the state level, depending on the political orientation of the state and so forth. And as a result, research that we've done at VCU has documented very stark differences in outcomes of the COVID-19 pandemic, which rather than taking years to observe, like the earned income tax credit or other policies, we saw the results of that almost in real time. How surge patterns, hospitalization rates, COVID-19 mortality rates change within weeks of state policy decisions being taken. We, of course, saw stark inequities in COVID-19 mortality based on socioeconomic status, but also very starkly for people of color, particularly African Americans and Hispanic Americans. These were the populations that had greater exposure to the virus. They were more likely to be the frontline workers who were working in retail and transportation and healthcare, and they had disproportionate exposure and were less likely to have the luxury of being able to work from home on Zoom, and instead were dependent on jobs that gave them greater exposure. At VCU, we've done research on how this affected life expectancy during the COVID-19 pandemic. Again, this is a graph from a BMJ paper that I don't expect you to be able to see given the technical problems, but basically what it shows is an enormous drop in life expectancy in 2020, which the whole country experienced. It was a massive decrease in life expectancy on a scale that the US hasn't seen since World War II. But when you break it down by race and ethnicity, you see that it was even worse for the Hispanic and Black population. In this particular slide, we're showing a decrease of 3.25 years in life expectancy for the Black population and a decrease in life expectancy of 3.9 years in the Hispanic population. These are massive numbers if you're familiar with life expectancy trends. A couple of more graphs here, which I don't expect you to see, but the basic takeaway from these is that Black and Hispanic Americans took a massive hit in life expectancy in the COVID-19 pandemic. This is data for 2020. We have papers coming out soon showing the same tragedy in 2021. So why the disparity in mortality? Why were Black and Hispanic people and Native Americans as well experiencing disproportionate death rates from COVID-19? Well, I list 5 explanations here. One is greater exposure to the virus, for starters, as I mentioned, in terms of jobs, but also overcrowded housing conditions and other living circumstances that heightened exposure to the virus. Second, susceptibility to complications. This is the population that is more likely to have comorbid conditions that increased the risk of hospitalization and death from COVID-19. Third, reduced access to healthcare, which obviously had a huge impact on outcomes. Fourth, greater economic vulnerability. So this is a population that went into the pandemic already with lower socioeconomic status on average than a privileged population. And then when the lockdowns occurred and the economy went into a tailspin, which population was most likely to be affected? And so we see a ripple effect from that. And because we believe in the social determinants of health, that leads to the fifth reason for more vulnerability is that lack of good jobs, that lack of housing stability, the lack of food security and so forth coming out of the pandemic will go on to have health consequences that are occurring in real time now, and we're probably going to be seeing unfold over the coming years. So again, Martin Luther King's line, we are made by history. Those five conditions did not pop up when the COVID-19 vaccine arrived for reasons we've already talked about. They were produced by hundreds of years of history. So the comorbidities that we sort of pass off as a quick answer for the disproportionate death rate from COVID-19, those comorbidities would not be at a higher rate in that population were it not for that history that created conditions that made it more likely for people of color to have cardiovascular disease, pulmonary disease, diabetes, obesity, and so forth. And when a pandemic like this comes along, they pay the price. And the preemption, that concept I mentioned around Flint, Michigan, that allows a governor to override local government, again, we saw on display in our daily news when governors were overriding mayors on issues regarding mask mandates and vaccine mandates. Mayors were taking steps, for example, in Texas, mayors of Austin and Houston and so forth were trying to implement policies to reduce viral transmission, and the governor was overriding them. This happened in Mississippi, it happened in Florida, it happened across the country. It's not just a problem that's going to be something we read about in terms of COVID-19. It's something that we're going to be dealing with going forward. We know from the fact that abortion laws are being passed across state capitals in the United States. Decisions about climate change are being made at the state level. We are seeing a movement toward increasing power at the states and increasing velocity of decision-making through state legislation that is going to affect public policy in a big way for many of us, has multiple ramifications, but health will be one of them. And in the context of this presentation, racial equity will also be one of them. So the degree to which states are able to reduce inequities or conversely exacerbate inequities, I think is going to intensify as we go forward. We've seen some examples of this in real life. You'll remember last year, the ice storm that hit Texas and they lost power. On the right is a photograph of Austin, Texas. And again, I don't expect you to see it, but on one side of the interstate, you can see the lights on, and the other side, it's dark as there's no electricity there. And then on the left is the redlining map from 1937 Austin. And the point is that the area that was redlined back then is the one with the lights out in the ice storm last year. One final slide, this is the last slide, and then we can go to discussion, is the one heartening thing I can share with all of this sad news is that I think we are living at a time where young people in particular and young people in the healthcare space have a new level of consciousness about these issues. So I take hope in the notion that the generation coming up able to make more transformative changes in the way we approach public policy can begin to try to break down some of these structural barriers that the dinosaurs who are still around now continue to carry on. And so I'm hopeful that, as we've seen from the Black Lives Matter movement and other social initiatives that have been going on, that the country hopefully can turn a corner. There's a dark side, of course, to this, that we know that we have a very polarized society, and some in our country are potentially interested in taking the country in a different direction. potentially back to what those black and white photographs look like. And that tension is going to be facing us for some time. But I try to be optimistic about progress occurring. So with that, I'll stop. I'm going to stop sharing this PowerPoint since you can't see it anyway. And I apologize again for the technical problems with the presentation.
Revealing and I hope helps give a backdrop to why we're taking an afternoon to talk about this biopsychosocial approach, even political approach to improving care in sickle cell disease. Thank you, Steve, for a dramatic presentation. I hope that our hearers and listeners learned a lot. I certainly did. We have lots of questions. I'm going to take the prerogative of asking the first question. Steve and I are working on a project. Steve, you may be able to figure out where I'm headed when I ask this question. It's going to take a disease-specific, or in this case, a discipline-specific approach to asking how policy might affect disparities with regard to race in the United States. And this project that I speak of that we're working on, as you know about, is the neurology project. And we are, Steve has generated on behalf of the National Institutes of Health, and we're trying to get published, a breakdown of the 880,000 lives lost analysis that he talked to you about earlier, that if there were similar health outcomes by race for patients with neurologic disease, how many lives would we save? And Steve, if you've got on the top of your head some answers there, the next question that we really can't ask, because there are not a lot of Caucasians that have sickle cell disease, but could we take an approach like that to try to get some traction to dealing with some of the institutional racism and some of the institutional barriers to care in sickle cell disease? Let's start with the first point was, tell us about that neurology project and tell us where we're at and what did we learn?
Well, and just as a prelude to that, to circle back to the point you were just making, Wally, is that, the data that I was showing for the most part of this presentation were life expectancy, all-cause mortality, very generic and global health measures. And it's really useful to start drilling down and looking at disease-specific disparities like the one you're mentioning, because first of all, that helps focus attention on where the priority areas are. But frankly, the mechanisms and the actual root causes for some of those disparities start to look a little different and more nuanced, depending on whether we're talking about depression or sickle cell disease or strokes in this case. So the neurology example, I'm trying to remember the results off the top of my head, but depending on what reference population you use, we'd estimate that we're losing we lost about 100,000 Americans because of the disparity that they faced in terms of mortality from neurologic diseases. And estimates like that are helpful because they're gripping. They sort of raise awareness about the magnitude of impact of these disparities. We as researchers can then start getting into the analytics to figure out which population groups and when do the temporal trends begin and so forth. But in terms of engaging the public and policymakers, sometimes those kinds of jarring statistics can get people's attention and give them a sense of perspective about how many Americans we're talking about.
Just to be clear for the audience, the neurological diseases that top the list that are responsible for some of those disparities are things like stroke, Alzheimer's disease, and the like. So in those populations, and I know everybody can relate to stroke and underlying hypertension and can relate to Alzheimer's disease and Alzheimer's-related dementia, Those are highly prevalent, highly relevant to the public. Sickle cell disease may be a little bit more less visible, and people may not be able to relate to it as well. But don't give me an answer today, but put your thinking cap on about what we might do to try to raise that kind of awareness. We've got a lot of jarring statistics already, but what could we do to raise more social awareness and outrage with the state of health in sickle cell disease? All right, here's a question from the audience. Are there any studies reviewing COVID rates in comparison to anti-mask, anti-vaccine, race, and ethnicity?
Can you repeat the question? Are there any studies?
Are there any studies, and I'm going to alter the question only slightly, comparing COVID rates to masking policies, vaccine policies by race and ethnicity? So I think they would say you go to a state that is anti-mask and anti-vaccine and a state that's pro-mask and pro-vaccine, and look at COVID rates by race and ethnicity in those states.
Yeah, I mean, I could actually go on for a while on that one. It's a great question, and it's actually something I'm currently working on. We had, just to take vaccines as an example, we had a concern when the COVID-19 vaccine first became available at the beginning of 2021, that vaccine hesitancy among African Americans would pose a barrier to uptake of the vaccine. This, of course, relating to the long history that African Americans have experienced of exploitation, Tuskegee, and so forth. And that was a real issue. It remains a real issue. But what's happened because of what's unfolded in our country, the politicization of public health during the pandemic, the dissemination of conspiracy theories, some of this state level polarization and how governors and state legislatures have framed their COVID-19 masking and mandate policies around their politics has resulted in the fact that states with overwhelmingly white populations are, first of all, less likely to enforce more robust public health policies like mask mandates or firm policies about promoting vaccination. And it's happening to the degree that we are now seeing that it's increasingly the white population that is experiencing disproportionate COVID-19 mortality because they have been less likely to accept what is a preventive intervention vaccination that is, more than 95% effective. Mm-hmm. So it's actually we're coming up with a paradoxical phenomenon with COVID-19 that we would not normally experience just because of the very unique circumstances that have occurred with the pandemic.
There's a question that I think is meant for me. It says, you alluded to a transactional relationship around sickle cell disease. This was in our earlier talk, Steve. Will we be able to make significant impact to the lives of those living with sickle cell disease if policymaking continues to be transactional? What sort of changes should we be advocating for? And Steve, by way of background, I was referring to the book Dying in the City of the Blues by Keith Wailu, in which the term transactional was applied to sickle cell disease. That is, it was thrown around as a pawn in order to gain political favor or in order to extract political transactions. And the question that they're asking is, if we keep making policy that way, what's going to happen? And can we not make policy that way? So that you could still participate in answering that question, because I think we've just been talking about that with regard to COVID.
Well, I'll let you lead with that, Wally, because that's a point you were trying to make in your talk.
At this point, I would say we don't have enough data. Our problem now is we don't have enough data to document some of the things that Steve just said with regard to how sickle cell policy is made. I would say we believe that sickle cell politics are real. We believe that there's transactional politics going on. But at this point, I don't know that we can say that we could go and show maps the way Steve just did with regard to policy decisions affecting sickle cell disease outcomes. What I can say is that we are advocating right now for federal policy change, and we will talk more about the National Academy of Sciences and Engineering medicine blueprint for sickle cell disease, which I don't view as transactional, and I do view as a way forward that is right-headed and contains policy recommendations, which, if enacted, I think would benefit sickle cell disease. So I'm like Steve. I'm trying to be hopeful. I'm hoping that we can come up with better solutions that aren't politics laced and based on race.
The only thing I would riff off of that with is that is to your starting point, Wally, that we don't have enough data. I think one of the research opportunities here to get questions like that answered requires the kind of interdisciplinary collaboration that, at least for me, has been new. Like many of you, I imagine, I studied a basic science in college. I majored in biology before I went to med school. And yet I find myself now in answering questions like the one the questioner just posed. You need to collaborate with political scientists. The project I just reported to you on in my slide presentation involved a collaboration with historians. I think increasingly we're going to need to work together, bringing in people who understand the law, politics, political science, sociology, history, and so forth, to start coming up with evidence-based answers to these questions that I think can be much more impactful than if we just do the research in our silos.
And I agree. And just one other word of hopefulness. Those kinds of scientists are coming out of the woodwork to work on sickle cell disease. It's been discovered, Steve, as emblematic. The comparisons that we're getting now are disease comparisons. So there are papers coming out comparing sickle cell disease to cystic fibrosis, to hemophilia, and to other diseases where federal policy has made a difference and showing not enough being done. But as you just said, we need to look at other kinds of policies other than within the healthcare system or within the research community, and ask questions about policies there as well. Payment policies, economic policies, social policies, employment policies, and the like. So thank you so much. This was stellar and very, I hear applause virtually coming from around the country. Thank you so much for your time.